Hello, this is Ed Kim,
And this is Alex Gupta.
and we're here at the VA, and we're going to do a little podcast on how to be more effective in the surgery clinic. So, the goals and objective is for you to become effective and efficient in evaluating surgery patients, and it starts out by figuring out why the patient is here, and then it really comes down to understanding different classes of patients that come to our clinic. And if you understand the different classes, it'll help you develop a focused but a complete approach to evaluating these patients and doing it in a comprehensive manner that will make your experience much better.
So, the first thing you do is figure out, well, why is the patient here in the first place? Is this a new patient or is this a follow-up patient? And you can discover that by looking in the consult tab. Starting with the follow-up type of patient, you can break them up into a few different subclasses. Is this a routine post-op follow-up? Is this to surveillance of a disease process post-op?
Or late post-op issues and sometimes pre-op. So this question of why the patient is here sounds really obvious, but it actually is not. Sometimes it can be a little bit confusing. The patients don't necessarily know at times. So, but you do definitely have to start here. So with follow-up patients, there are different classes of follow-up patients. So you got to figure out what they are. And the first way to figure this out is that they're following up with us usually because they've had an operation. And so you look under the surgery tab to see if they had an operation. If they've had an operation, then you want to figure out what operation they had, why they had it. And in order to do that efficiently, you don't have to read the entire report. There should be a summary at the beginning of the operative note telling you when, and what was done. And if you don't understand that, the abbreviation or whatever the terminology is used, you can use the internet to find out quickly.
And when you're looking in this, the date of the operation is especially important because it can help you determine what type of follow-up this is. Usually if they're following up 1 to 2 months after an operation or sooner, it's a routine surveillance follow-up just to make sure they're doing okay after the procedure. Oftentimes in the patients who are here 2 months or more after the procedure, this is a longer-term follow-up and we might be looking for some different complications or other complicating factors related to the operation.
Yeah, they may have had a prior routine follow-up already, right? So routine follow-up. So this is somebody who's had an operation and went back home. And so what you want to do is review the op note or the brief op note again for the basic information we talked about. And the discharge summary is also important because you want to know what the post-op course was like, whether there were complications, because these usually lead to follow-up issues, meaning the things that we have to make sure are all fixed or back to normal or in a acceptable situation.
And these can be especially helpful for patients who had a pretty complex hospital course, because you can look at the DC summary and get a great sense of the entire course of their hospitalization and any complications that might have occurred while they were there.
Yes, like for example, if they had a PE, they would go home on anticoagulation, and we'd have to make sure that their anticoagulation is being followed by somebody, or if they had an abscess that required a drainage, they would have a tube that needs to be followed up. So these are, or a wound, open wound, if they had a wound infection. So it's very, very important that you understand. If it's a simple follow-up, meaning that the operation was uncomplicated and the patient went home in an uncomplicated state, then it's not that big of a deal.
So in these routine follow-ups, you kind of want to break up your approach to it in a few different ways. The first thing you should do with a routine follow-up is figure out kind of a list of questions you want to ask the patient, and this can either be a written list or you can just think about it before you go in. And then when you go in, some good things to be thinking about are just an overall sense of how the patient's doing. How is their energy level? Are they back to normal activity? How are they feeling about everything? Other parts of this include pain. And in this, you kind of have to look a little bit deeper. If somebody had a big open abdominal procedure, they're going to be in more pain than somebody who had a small lipoma taken off of their shoulder. Other things to look for would be things like fevers, which could be concerning for an infection. And then especially for any GI operations, you want to ask them if their bowel function has returned somewhat to their baseline. Of course, also, looking back at the DC summary, you want to follow up with any issues that were mentioned in the DC summary. You can take a look at the pathology report if there was any specimen taken during the procedure.
Not can, should.
You should. And you also should look at any follow-up imaging or any lab tests that were drawn during the hospitalization that were not yet completed at the time of discharge.
Yeah, sometimes they'll have a lab or follow-up imaging prior to coming to clinic on that same day. Okay. So the encounter. So when you see the patient, ask your questions, right? Sometimes they'll have a lot of non-specific aches and pains, that's what I think derails a lot of medical students. Because this type of patient, this routine follow-up patient, unless they had a very complicated post-op course, should really take about half an hour at most from the start of looking up their history to seeing the patient and for the presentation. I think we've definitely have had students, especially earlier in the year, that spend an hour on a routine follow-up patient and we're wondering what's going on behind those doors. So try to avoid tangents, stick to the focused approach. If they have some specific aches and pains, you don't necessarily have to go chasing into them, especially if they're related to pre-existing conditions or whatnot. You can note them, but you don't have to elaborate and go into the whole what was the quality, what are the associated symptoms and whatnot for everything.
And that's true for the physical exam as well as the history. When you're doing the physical exam, try to really stay focused in examining, the aspects related to the case that we did. Look at the wound, of course, if there's a wound. You should examine the abdomen in an abdominal case. Very briefly, get a sense of how they're generally doing. How are they respirating? How's their chest function? Take a listen to their heart, of course. Make sure they're no edema or anything, and peripheral pulses are intact. Things along that line. And then, of course, if there were any specific issues that needed to be followed up on, do a physical exam related to those things as well.
So presentation-wise, it should be pretty brief. You talk about the type of the operation, date of the operation, why it was done. That's all basic. Summarize the post-op course, meaning the patient. You could say, this is a patient who had a esophageal cancer, had an esophagectomy, 3 weeks ago, and had a uncomplicated post-op course. Did okay. There was no major issues. Now here for the general follow-up. And then you can have a general sense of how they're doing. You can tell that that they're doing well, and then go over the specifics why they're doing well. Energy levels are better, eating well, not having issues. And then restate the general assessment that they're doing well, and then plan for whether they need additional follow-up or not, depending on what the findings are, whether you are reassured by how they're doing or not. But I'll say, psychologically, Alex, that sometimes it helps, especially if it's a big operation with complications and whatnot, to start out with the assessment and saying, Dr. Kim or Dr. Corvera, Dr. Stewart, Mr. So-and-so is here for follow-up. He had that operation and he's doing great. And because it actually puts us at quite a bit at ease, because all of us feel a little bit anxious when we see our patients post-op, especially the ones that did have some issues, that in the hopes that they're doing well. So it really does relieve our stress to hear that they're doing well first, right off the bat, rather than saving it to the end.
So that kind of summarizes the routine follow-ups. Now we'll talk a little bit about the patients who are here for long-term follow-ups. These are a little bit more complicated because they're more heterogeneous in the type of patients that they could be. These could be patients with ongoing issues after routine follow-up that required further follow-up. These could be patients who initially were fine on post-op examination, but later developed complications, things like hernias or things of that nature. And then also these are patients who are here for surveillance of their disease process. Maybe they had a tumor resected and they're here for follow-up, they've had imaging, and they're here to make sure that they're still have not had any disease progression. So when you're looking at these patients, one of the first places you should look is at their prior follow-up notes, specifically looking at the assessment and plan that was made at that time. This can give you a lot of an indication of generally how the course of this patient, how they should be looking right now, and can tip you off ahead of time of, are they in line with that plan from a few weeks ago or a few months ago, or have they again derailed from that plan that we had at that time? So again, looking at the simple things, look back at what the operation was, why was the operation done, what was the inpatient postoperative course like, and then of course looking at how has the outpatient postoperative course been for these patients too. And then just as before, looking at any labs or studies that were planned previously that we need to follow up on during this visit.
Right, and I think the key, the potential pitfall might be that it's hard to know how much detail you need to know about the initial operation and what decision making with that, and you don't have to go that far into it. You just need to know basics of the and hopefully this would be in your prior follow-up note, meaning that you don't have to go read the first consultation visit note that we had before the operation. That's not necessarily. If the follow-up note that the routine follow-up or the last note that was written is usually a good enough reference for you to get the basic information, that's enough. You don't have to go read the whole thing, and because that will take you way too much time and provide you with details that are not necessary. So the encounter, again, list, inquire about general status, focus on the reason for the continued follow-up, whether it's surveillance or whether the patient developed, like you said, a hernia or a new infection for whatever reason. Do the same, focused, and then the presentation again, basic information, reason for follow-up, summarize the findings, okay?
So another type of patient might be a patient who's following up, but we're still preoperative on these patients. So these patients are kind of interesting because oftentimes our pre-op patients, we might see them one time, schedule surgery, and then take them to the operating room. But in these patients who are following up for a second time, we have to kind of figure out, well, why did we need multiple preoperative appointments? The first thing you should do is look at the first consultation visit and figure out, of course, the history of the patient, but more so, what was the assessment and plan at that time that prevented the patient from being able to be going straight to surgery. So look at the assessment and plan. Why was a follow-up necessary? Are they here because we asked them to come back and see us again, or have they had another complication between us seeing them the first time and then coming back to see us a second time now? Additionally, in the interim, they maybe came and saw us the first time and they have additional studies that we wanted to follow up on. Some of these could include things like maybe they're not very fit and we wanted to get pulmonary function tests, or they needed to get cardiac clearance before the operation. These are all good things to know.
Yeah, so the encounter, basically interval history, make sure they haven't had any major changes, otherwise you don't need to go and redo the whole history. Please don't redo the whole history. Do the basic exam, confirm the resolution or the completion of whatever follow-up issues there were, and then at your presentation, the attending is not going to remember the patient just by their name, so you got to tell them what the diagnosis was, what the initial evaluation plan was, and what the follow-up issue, what we were trying to get additional information on, and present those additional information. So, new patients.
The dreaded new patient where you don't have a note to go and give you a nice outline beforehand to figure out why they're here. So really the biggest question you have to figure out is, why are they here in the first place? And a good first place you can look to figure this out is in the consultation tab. Oftentimes there might be a note or a consultation report in there that can give you an idea of why they're here.
Oh, and I think I should, for the VA specific students, in the consultation tab, if it says IFC, that means interfacility consult. That means that patients coming from non-San Francisco VA, and their data will be on Vista Web, not on our CPRS. So you have to go outside. And then the DC summary is another source because that's for patients who may have been admitted with a surgical problem, and the decision was for them to come follow up afterwards to make sure that they're resolving, or to plan an operation potentially. Okay, and then lastly would be the notes. Just general notes for new patients is a very, very inefficient way to look at things, unfortunately. And
then also, trying to figure out, this is a new patient, but are they here because we're trying to diagnose them with a disease, or are they here because they have a diagnosis already and they're being referred to surgery for a surgical treatment?
Okay, so yeah, and then we'll go over this concept of diagnosis or a treatment-focused patient. There's going to be another podcast, and so the next few slides we'll go over pretty quickly to kind of go over this concept of splitting or categorizing a patient based on this distinction. So for the treatment-focused patient, the diagnosis has been confirmed by standard, reliable means, which you may not be aware of, in which case this is where you need a little bit more assistance and guidance on whether that's, whether the patient has a confirmed diagnosis. And the goal of the history is basically to compare to what the classic clinical presentations are. So this is a little bit backwards, meaning you already have the diagnosis, You just want to know what their story is like and how that compares to what you read in a textbook or in a reference. So the only way to do that is to basically go to a reference. So for a new patient, what you want to do is, if this diagnosis is confirmed, you want to go open up a web page or take out a handbook and figure out what the classic presentation is, findings, labs, and evaluation. You have to do this quickly because obviously the pace of the clinic can be sometimes fast, but you need to at least have a basic understanding of how people present and what the evaluation is, or else you're going to have a really hard time evaluating the patient. It's not just a blank white sheet and you go in and try to find out by talking to the patient what's going on. Okay, it's very focused. So in the encounter, have the mental list, start with the general interview, focus on the questions that you know are classic for the disease, do the full past medical history. This is a new patient, right? So you have to assess what their past medical history is in light of trying whether they're fit for surgery or not. Do a full exam, review the labs. And then what you have to recognize is that sometimes patients don't come with the complete evaluation. So they may be missing certain labs and studies that you would read in your reference textbook, website, whatever, that tell you that this disease is diagnosed and management is determined by these studies, but the studies may be absent. And that's a very important pertinent negative for you to mention.
And one other thing also that's really important here, a pitfall to avoid, is although these patients might already carry a diagnosis, don't forget that these patients were referred to us for treatment, and the diagnosis that was made might be made by somebody who isn't a surgeon. And so while, of course, you can use the diagnosis that they carry to help guide you, it's important that the history you take confirm that diagnosis they carry, because the diagnosis might not be an appropriate one, and in fact it might be a different disease process going on, and that's our job to determine.
Yeah, so at the presentation of the patient with a fairly confirmed diagnosis, start with the diagnosis, not with the symptoms. Describe all the history and all the relevant data. Most importantly, describe the history or the aspects that don't fit and the studies that haven't been ordered. Okay, I say most importantly because the pertinent negatives are just as important as pertinent positives, and I think it's important at the start, when you're just starting out as a student, to kind of understand that not everybody presents classically and that you see the variability in how people present. Past medical history should focus on whether they're fit for surgery or not. Repeat the objective data, and then assessment and plan. Please don't belabor the differential diagnosis. The diagnosis is already confirmed. We don't need to know why you think that the patient has a diagnosis, that these were the differential and this is why we think he has what he has, when it's, a biopsy confirmed colon cancer is biopsy confirmed proven colon cancer. If he presented initially with rectal bleeding, we don't want to know about the possibility of the hemorrhoids or anything else. That's not relevant at this point. More important for you to focus on is to think about what the treatment options are and recommend the treatment option. Know what the treatment options are. This should come from the reference reading. The reference should say treatment for hemorrhoids or treatment for inguinal hernia is this, this, and this. These are the options, and then you have to choose which one would be the best one for your patient.
So now we can approach a different type of patient, kind of turn that upside down. This is the patient who is coming to us because they need a diagnosis. So this is a patient who maybe has a presumed diagnosis that's not confirmed yet, or maybe this is a patient just with a list of symptoms that is here for us to actually figure out
I'd like
what's going
to
on.
edit that just a little bit, Alex, if you don't mind. So they don't necessarily come to us for the diagnosis, but oftentimes they come to us with, not necessarily, part of it is for us to make the diagnosis, but part of it is for us to make the diagnosis and come up with a treatment plan.
In these patients, we're a little bit more focused on the history as well. So, of course, we want to take a broader approach to gathering data to help confirm or determine the diagnosis. So you might start with a differential based on a primary symptom, look up reference of symptoms that might kind of coincide with this differential diagnosis to help you organize your thoughts and maybe direct you toward a specific diagnosis.
And I think this is the part where they do come oftentimes labeled with the diagnosis, because the people who send them to us, again, will send them to us because they think that the patient might need an operation. So they already have kind of a diagnosis that they're thinking of. So what your point on the prior slide where you say don't accept what people tell you, or what the referring physician tells you is the diagnosis, is an important point. You want to avoid a confirmation bias, because and the reason why they're sent to us, like I said, is it's not only for treatment, but because we're also experts in making the diagnosis for some of these type of symptoms. Okay, so the encounter is, again, it's pretty straightforward. These are things that I think you guys have done more of. It's more in medicine and in your first couple of years. And then with the presentation, I think the major differences are start with the symptoms. Don't start with the diagnosis, because we're not sure about the diagnosis. And your history is to make an argument for that specific diagnosis that you think is most likely. But also mention the ones that don't classically fit also, as well as the ones that do fit. Okay. And the past medical is pretty much the same as the treatment in terms of focusing on whether they're fit for surgery, of the data. So assessment plan's a little bit longer, because you do have to go over the differential a little bit and say why you think, let's say somebody comes with rectal bleeding, why you think the person has a fissure, not an anal, a fissure rather than a hemorrhoid. You're going to have to make that argument as you would typically do. But then you can't stop there. You have to then go on to the treatment part, where you state the treatment option and take a stab why you would do one versus another in this type of patient. Okay, so I think I don't have a summary slide here, Alex, but I think it's fair to say that there are specific types of patients, and when you recognize what type of patient you're dealing with in surgery clinic, it allows you to change your approach a little bit to be more effective.
It definitely helps you kind of simplify the way that you approach this patient. It can help you to direct a little bit more of the history and the physical exam that you do. And walking into the room kind of knowing why this patient is here can really help you to take a better history and can help your presentation as well.
Great. Thank you very much.
Thanks.